Dr. Sue will now introduce our next speaker, Dr. Thomas Hope.
Dr. Hope's going to give us an update on genitourinary cancers, and we welcome Dr. Hope to the Nebraska Oncology Society and especially appreciate his short-term joining us. Dr. Hope is the Vice Chair of Operations and Strategy in the Department of Radiology at University of California, San Francisco. He serves as the Director of Molecular Therapy as Chief of Nuclear Medicine at the San Francisco VA Medical Center. And he also serves as chair of the Cancer Center's Molecular Imaging and Radionuclide Therapy Site Committee. He received his medical degree from Stanford University School of Medicine. He completed residency in diagnostic radiology at University of California, San Francisco, followed by a clinical fellowship in body MRI and nuclear medicine from Stanford Medical Center. His main research focus is on novel imaging agents and therapies, particularly in prostate cancer and neuroendocrine tumors. He led the development of gallium-68 PSMA11, which subsequently led to the approval of this drug by the FDA. He has combined his interest in MR imaging with PET in the simultaneous modality PET/MRI, helping to lead the development of the clinical PET/MRI program. Additionally, he leads the peptide receptor radionuclide therapy program for neuroendocrine tumors and PSMA radioligand therapy at UCSF. Welcome, Dr. Hope.
Welcome. I definitely need to shorten my biography on my webpage. Thank you for introducing me. I apologize to everyone that the speaker you expected is not going to be here and you are stuck with me. And also I apologize that I'm not a medical oncologist. I'm a radiologist and nuclear medicine physician, but hopefully as you'll see here in the next 30-40 minutes, molecular imaging and radioligand therapies are going to play a huge role and are already starting to play a huge role in the management of patients who have prostate cancer. So if I want to screen share, I can steal from you. Yes, it will let me steal.
Yes.
Okay, so here is what I'm going to talk about. We're going to talk about molecular-based imaging, and also I'm going to add in some theranostics there and redefining the landscape of prostate cancer. So these are my disclosures. So we're going to start, and actually this whole talk is going to be focused on PSMA, right? My world, in essence, has become PSMA-centric. PSMA stands for prostate-specific membrane antigen. PSMA is overexpressed on prostate cancer cells, and it's obviously very useful for detecting where metastatic disease is in patients. But interestingly enough, the name is not appropriate because it's not specific to prostate cancer. It's actually expressed across a lot of different cancer types, including lung adenocarcinoma, glioblastoma, ovarian cancer, thyroid cancer, etc. But it still functions very, very well. Now, here's an example from when we first started using this, and I give this slide because I just think it really highlights how valuable PSMA PET can be. So this is a 69-year-old man. He underwent a radical prostatectomy a couple years prior, and he had biochemical recurrence with a PSA of 0.7. Now, historically, the standard treatment of a patient like this would be to get prostate bed salvage radiotherapy, right? Maybe with 6 months to 2 years of ADT, depending on what type of risk factors the patient had, right? And that would not work in this patient, right? His disease outside of the prostate bed, it goes up into the bones. And so this would completely change the management of this patient. Had we not had this PSMA PET, he would have undergone that salvage radiotherapy and ADT, and we would have treated the disease the patient actually had. And then he would have immediately biochemically recurred when his ADT was withdrawn. The other thing about this case that I really like is it highlights that, historically we've imaged patients with multiple imaging modalities at each time point. For example, we get a CT scan to look for nodal disease. We get a bone scan to look for bone disease. So not only is PSMA PET better for detecting disease, right? We have a higher detection rate, but additionally, it combines together soft tissue and osseous characterization simultaneously. So we're now finally in an era where patients can get staged with a single imaging study instead of multiple imaging studies that might take multiple days to acquire, which was much more patient-centric. Now, it's a little confusing because there's lots of these agents out there, and it's pretty easy to get these agents to market. Hence, we at UCSF are actually able to bring a drug to market compared to a therapeutic, which is much more difficult. So right now in the bottom left there, you can see DCF-PYL. That's brand's name is piflufolastat or Pylarify. It's a fluorinated agent, and that's probably the most widely available agent in the United States. The bottom middle is PSMA-11. That's the agent that we got approved at UCSF in collaboration with UCLA. There are actually now 2 kits that are manufactured by other companies. We made it as a generic, a non-proprietary NDA so that any other company could make it as well. So that's becoming obviously much more widely available, although it was first approved. In the bottom right there is PSMA-617. This is what was used, as we'll talk in the very end, in the theranostics as a therapy labeled with lutetium to treat patients, and was in the VISION trial, is now FDA approved as of March. And the top row were 2 additional agents that are in phase 3 clinical trials, PSMA 1007 and RH-PSMA-7. So there'll be more and more of these radiopharmaceuticals available in the market for staging of patients. The point I want to make is they all share the same urea motif. This is what binds to PSMA in patients, and it's really makes it like a class. I think of them functioning nearly identically in terms of detection sensitivity, and you'll see data in a second that shows really the results from DCFPYL or piflufolastat is nearly identical to what we see with gallium-68 PSMA-11. And so in my mind, I think of these very similarly, and I would be no issue using one versus another agent in patients. And I think that's an important point to you if you're managing patients with prostate cancer. Now, I mentioned that it's not specific. And one of the things that's not specific is these benign lesions. And so here's an example of a rib lesion, which has pretty good uptake. It looks pretty hot there on the PET image on the right, but that's actually not prostate cancer. That's probably an aneurysmal bone cyst. And you'll see a lot of these solitary rib lesions in patients with prostate cancer, and they are not metastatic disease. And there was a nice paper that looked at something like 60 to 70 patients who had solitary rib lesions at the time of initial staging, and none of those lesions ended up being metastatic prostate cancer. So just be aware that we'll see benign lesions such as rib lesions. We'll also see ganglia. So here's a presacral ganglia. This is an anatomic finding I never paid any attention to prior to PSMA PET, but now when you look for them, they're these anterior posterior oriented lesions in front of the sacrum. We also see dorsal root ganglia and hemangiomas. Other benign lesions like this is a Paget's disease, has uptake on PSMA fibrous dysplasia. And then, as I mentioned before, other tumors. So here's an example of a lung cancer that can have pretty avid uptake on PSMA PET. I think the only cancer that really is going to be confusing with prostate cancer is lung cancer, except they typically have a slightly different appearance, spiculated margins, et cetera, on CT, so you wouldn't generally get confused, but it can be confusing. I would just make sure you take into account patient history. Someone's presenting with Gleason 3+4 disease and you see a lung lesion, that's obviously more likely to be lung cancer than someone with metastatic CRPC who has growing lung nodules with their PSA rising. Overall, I think these are actually true negatives with good training, and you can actually interpret these properly. I want to mention to you as clinicians, though, because sometimes your radiologist might not be as familiar with PSMA PET. So just in the back of your mind, realize that there's a couple of these lesions, and if you see a rib lesion, maybe have a sneaking suspicion that that's not going to be metastatic disease. Now, I want to take a quick second to compare this imaging study to fluciclovine. So fluciclovine is the PET radiopharmaceutical that was FDA approved in 2016 prior to the availability of PSMA. And it was very widely available in the United States. And it worked reasonably well. So here's a case of a patient who had a right pelvic sidewall lymph node. And the tumor to background ratio here is around 3 with fluciclovine. But you can see with PSMA PET, the tumor to background ratio is something like 50 or 60, right? So much higher uptake in the tumor and better clearance in the background, which obviously aids in interpretation. Now, in this patient, obviously it made no difference, but in this patient, you can see the patient has a right seminal vesicle recurrence there after radiation therapy. The tumor to background ratio on fluciclovine is under 2, and it's pretty hard to appreciate that. On the PSMA PET, it's very focal. You have a tumor to background ratio a little under 10, and you're much more confident in interpreting that as being recurrent disease. Now, this comparison played out in a head-to-head comparison UCLA ran from Jeremy Calais. He took patients and imaged them with PSMA PET and fluciclovine within a week of each other, or maybe 2 weeks of each other. And he showed that PSMA PET had a much higher patient-level detection rate, so saw more sites of disease than fluciclovine did, right? So more than 2-fold increase in the patient-level detection rate. And then also, I think more importantly, if you looked at the locations of recurrent disease, and remember this patient population was patients who had a radical prostatectomy biochemical recurrence with a PSA less than 2, so patients where you're looking for extra prostatic disease. PSMA PET really saw only extra prostatic disease, whereas fluciclovine was seeing stuff in the prostate bed only. And so that really highlights the value of PSMA PET, seeing that metastatic disease, which is going to change the management in patients. I think the other thing that's important is, consistent with what I was just showing you, the increased uptake with PSMA, the inter-reader variability is much lower, or the confidence or the Cohen's kappa is much higher. So with PSMA PET, the Cohen's kappa is nearly 0.7, whereas with fluciclovine is 0.2. Remember that 1 is perfect agreement within readers, 0 is perfect disagreement. So 0.2 is actually pretty low of a way or inter-reader agreement with fluciclovine. One other comment, there are going to be people out there who try to tell you that different agents are different. So DCF-PYL, or this piflufolastat agent, was studied in a head-to-head trial compared to PSMA-11. And this paper tried to conclude that DCF-PYL was better than PSMA-11, but they gave, 5-fold higher dose with DCF-PYL, had 2-fold increased uptake time. And this was the image they showed in their paper showing that DCF-PYL outperformed PSMA-11. And you would never perform a PSMA-11 PET imaging study with this low of a dose. It's outside of the, it's about probably 3-fold lower dose than you would actually give. And so, this comparison is actually just showing something different, which is that the imaging technique matters more than the agent, not that the agent makes a difference. So to me, scanner and acquisition protocol is more important than the radiotracer used. And for you as an oncologist, the most important thing is the best PSMA PET agent is the one the patient can get. So don't worry about if it's DCF-PYL, piflufolastat, or gallium-68 PSMA-11. They are in essence identical. So just make sure we're imaging patients with this new radiotracer moving forward. Okay, so I'll quickly talk about initial staging. And so the FDA approval for PSMA PET includes initial staging in prostate cancer. Both SNMMI and NCCN guidelines include it in unfavorable intermediate risk and high risk and very high risk patients. Okay, so it should replace the use of bone scan and CT in those patients. The interesting thing is if you look at the company-sponsored trial for DCF-PYL and our trials at UCLA and UCSF with PSMA-11, we ended up with, in essence, the same sensitivity, the same specificity, very similar number of patients, et cetera. So it's very interesting that we had very similar outcomes. But I think the important point here is that sensitivity is surprisingly low, right? So we didn't see all of the patients' nodal disease, and these were comparing to pathology at prostatectomy. So we were looking at PSMA PET results compared to pathology at time of surgery. And we only saw 40% of those nodes. And that's because many nodes are, 1 or 2 millimeters in size, and they're very hard to see. But when you do see disease outside of the prostate, it's tumor. The specificity is 95, 98%. We're very good at seeing the recurrent location of disease, or actually the metastatic location of disease. And one of the effects of this is in radiation therapy planning. So radiation oncologists use PSMA PET a lot at UCSF, and here is a series of high-risk patients at staging who we imaged using PSMA PET. And in these 3 columns, it shows the different changes in management. So in column A there, those are patients who had nodes within the consensus tumor volume that got boosted. 6 patients had bone disease outside of the consensus tumor volume, and 8 patients had nodes outside of the consensus tumor volume. So over 50% of patients had a change in their radiation therapy planning when using PSMA PET for definitive therapy at initial treatment, which is really an impressive change for this patient population. Now, biochemical recurrence might be more relevant to you as a medical oncologist. There's 2 major trials, one by DCF-PYL, funded by a company, and then our academic trial on gallium-68 PSMA-11. We had, again, pretty similar results. So you can see that our positive predictive value or correct localization rate, you can sort of think of those as being the same. The idea really being that if we see a site of disease, is that cancer or not? They're both around 0.85, 0.9. The detection rate on a patient level, again, very similar between both patient populations. So obviously, the lower your PSA, the lower your detection rate is going to be on a patient level. And I'll show that in another slide as well. These 2 trials obviously led to the approval of PSMA PET in biochemical recurrence for both DCF-PYL and PSMA-11. Now, I want to take a moment to talk about conventional imaging, and it's very frustrating. If you order these imaging studies, insurance companies may require you to get conventional imaging first. And because we anticipated that, we worked with the NCCN to insert this phrasing into the NCCN guidelines. And I think it's really important. So it states the panel does not feel that conventional imaging is a necessary prerequisite to PSMA PET. So the idea here is we don't need to do a CT and bone scan and have that be negative before we do a PSMA PET. The value of PSMA PET is so much higher than conventional imaging. Not only will it find disease in conventional imaging negative patients, it might find additional sites of disease in people who are oligometastatic. So no matter what, we should try to just image patients with PSMA PET rather than get conventional imaging as a gatekeeper to PSMA PET. So if an insurance company gives you a problem, hopefully you can use the NCCN guidelines to push back. Sometimes it works. I think the biggest issue with reimbursement or pre-authorization is the initial staging setting, where it is definitely included by Medicare patients, but there are private insurers who will not approve PSMA PET in the initial staging setting. Here's that slide I promised showing the increase in detection rate on PSMA PET as the PSA increases. The higher your PSA, the higher your detection rate. One thing that's really important here is, in general, I want to make the point that we don't wait for patients' PSAs to rise to get a PSMA PET. Now, it obviously depends on the individual patient, but if you have a patient who you're planning on undergoing salvage radiotherapy after prostatectomy, why would you wait for the patient to develop metastatic disease so that you can image it with PSMA PET, if that makes sense? So the idea of waiting for a higher trigger PSA prior to getting a PSMA PET is sometimes a little flawed. Now, if you're thinking of using oligometastatic targeted radiation therapy and you've already done salvage radiotherapy, in that setting, maybe it's useful to wait a little bit if you've already used salvage treatments, et cetera. Now, looking in that patient population again, patients with a PSA less than 2 after radical prostatectomy, we looked in those patients at UCSF as well, and half of those patients had PSMA positive disease, and 30% of the 125 had PSMA positive disease outside of the radiation therapy field. That's pretty impressive, right? That means a third of patients who were getting salvage radiotherapy, people weren't getting radiation therapy that would cure the patient because you weren't treating the entirety of the disease, right? And so this is really how PSMA PET's changing the management and impacting care in these patients with biochemical recurrence. Now, this type of imaging was studied in the EMPIRE-1 trial. This is out of Emory, where they compared fluciclovine to conventional imaging, so not PSMA PET. And they showed that when you did metastasis-directed therapy plus salvage treatment in a radical prostatectomy biochemical recurrence patient population, the use of molecular imaging with fluciclovine improved biochemical-free survival at 4 years, right? So improved patient outcomes when using molecular imaging to plan your radiation therapy. Now, with PSMA PET, we see huge changes in management, similar to what we just showed, right? So if you have no disease, we have patients being trending towards surveillance. If you have nodal disease, they get towards radiation therapy or metastasis-directed therapy. If you have metastatic disease, you're going to get more likely systemic therapy, right? So these management changes on PSMA PET happen in about 50% of patients who are imaged with PSMA PET. And similar to the EMPIRE-1 trial, moving forward, we have this study, which is very interesting. Again, UCLA taking the lead with PSMA PET. This is a randomized trial comparing PSMA PET CT to standard of care imaging, again in the post-prostatectomy patient population who are being planned for salvage radiotherapy. This was presented in an abstract of the management changes at ASCO this year, and hopefully by the end of this year, we'll get some outcomes data showing that PSMA PET did improve patients' outcomes compared to conventional imaging. I think it'll be very interesting to see how the results of this study compare to fluciclovine. Fluciclovine might show you the majority of the disease, right? It's lower sensitivity, so you're seeing bulkier disease, so maybe it's picking up the most clinically relevant disease, whereas PSMA PET might be showing more small locations disease, but I think that there'll be a much improved outcome with PSMA PET compared to fluciclovine, and we'll look forward to the results of this study in the coming year or two. Now, one comment about PSMA negative disease. So here's a patient who is at initial staging. They got a prostate MRI on the left, and you can see in the top left here, this is a high B value DWI or diffusion weighted image showing restricted diffusion on the right side of the prostate. This is the ADC showing that restricted diffusion low on the ADC. On the PSMA PET, you just don't see anything there. This is a PSMA negative tumor. That happens, maybe 5% of patients have PSMA negative tumors. Now, if you read in the literature, you think PSMA negative tumor, that's really bad, right? And that's because of papers like this, where we looked at, and I didn't do this, this paper here was in patients who were from Australia and other European sites who were being treated with PSMA targeted radioligand therapy, and in patients who had FDG PSMA mismatch, meaning PSMA negative tumors that were FDG positive, patients had an overall survival of 2.5 months. So in the mCRPC setting, late in the management of patients, PSMA negative disease is really bad, but that's different than in the initial staging. So this is some data out of the primary trial, which was published in European Urology last year. And you can see the SUV, or the uptake, goes up in patients with higher grade tumors. So at initial staging, lower uptake actually is better, and patients do better with lower uptake. Okay, so I think that's really important, is initial staging, lower uptake is actually better. Now here, I think this is also an important point, which is that if you look at the outcomes of salvage radiotherapy in patients who have a negative PSMA PET, okay, those patients do much better than patients with metastatic disease. And on the right side, you can see that that's also true independent of the PSA at time of imaging, which is interesting because usually the PSA is actually very prognostic, but it's actually the location of the disease outside of the pelvis that's much more important. And again, this is really highlighting, don't wait for patients to have a higher PSA so that you can see metastatic disease. You should treat them with salvage radiotherapy. And what you want is your patient to have a negative PSMA PET. It's interesting that I feel like patients want to have a positive PSMA PET because they know where their disease is. It's actually obviously better to not have a positive PSMA PET because those patients do better in the long run. Okay, so how does this imaging study impact the prostate cancer landscape? So in the castration-sensitive prostate cancer setting, we think of localized prostate cancer or metastatic prostate cancer, and maybe we'd stratify those by genomics or PSA or low or high volume disease. And, for example, in the CHARTED trial, right, this was what got docetaxel plus ADT used in the metastatic castration-sensitive setting. They stratified patients to have low or high volume disease, and only in high volume disease did the addition of docetaxel outperform ADT statistically. Okay. Now, this was based on 4 more bone metastases on bone scan. So now we have this issue of, okay, goodness, what is 4 bone metastases with PSMA PET? Now that we have PSMA PET, we can see disease better. We might see more bone lesions than you would with bone scans. So maybe should it be 8 lesions with a PSMA PET versus a bone scan? So you can sort of see how PSMA PET is going to cause a lot of issues with inclusion criteria based on conventional imaging. But at the same time, I want to ask the question of, does PSMA PET always upstage patients? So here is the STAMPEDE MTR1 arm. So in STAMPEDE, one of the arms of STAMPEDE took patients and randomized them to getting abiraterone and ADT, and then they randomized them within that to getting prostate bed radiotherapy. So these are M1 patients at initial treatment, so they still have an intact prostate, and some patients got radiotherapy to the prostate bed. And in this trial, you can see here that in patients who had a high burden of disease, so greater than 3 metastases, sort of like CHARTED criteria, there was no benefit to radiating the prostate. But if patients had less than 3 metastases, prostate bed radiation therapy was beneficial. So this is sort of the opposite of CHARTED, right? CHARTED is high volume, we add treatment, and this one is low volume, add treatment. But let's think about this. Bone scans, low volume bone scans are frequently false positives. So maybe 20 to 25% of patients who have low volume bone scans, you're going to have a negative PSMA PET, and that's not actually metastatic disease. So therefore, when you're treating the prostate bed with external beam radiation therapy, you're actually curing that patient, right? It's a curative intent, definitive treatment. No kidding, in low volume patients, you're actually going to have an improved outcome because about a quarter of those patients are going to have a cure by treating their prostate bed. So it's very interesting how different PSMA PET can impact different disease settings, and we obviously need to learn a lot more about how to do this properly moving forward. So if I think about the castration-sensitive setting, now I'm thinking more, hey, PSMA negative, oligometastatic, low volume versus high volume. We haven't really defined low and high volume on PSMA PET yet. Now, in the biochemical recurrence setting, we typically think of biochemical recurrence, M0 disease versus metastatic disease, and again, using some prognostic factors. And so here's an example of a patient who has PSMA PET was M0 on conventional imaging. And you can see, for example, the supraclavicular node, which only measures about 4 or 5 millimeters on conventional imaging, clearly avid on PSMA PET, dramatically changes this patient's management, right? This patient might have gotten salvage radiotherapy. Maybe we would have irradiated a node in the retroperitoneum there, but all of those were sub-centimeter, so we probably didn't even know they were a tumor. And so this is completely changing the way we're thinking about patients in the castration-sensitive biochemical recurrence space. So we might actually be converting this to a similar thing, right? PSMA negative, oligoacidic, low volume, high volume. This is changing the way we're thinking about these patients, right? And oligometastatic being important because we might start doing more metastasis-directed therapy. And I put the word might in there more facetiously because radiation oncologists are using this imaging study to do quite a lot of metastasis-directed therapy, sort of becoming whack-a-mole, right? You see a new lesion, you irradiate it, PSA rises, you do another PSMA PET, you irradiate it, and there's a lot of patients being managed that way currently. Now, in the non-metastatic castration-resistant setting, this is sort of a pharmaceutically developed patient population to get drugs approved, right? So the wow, I'm blanking on trial names here, I apologize. But there's now 2 to 3 androgen receptor targeted therapies approved in the non-metastatic CRPC setting. And when you look back with PSMA PET, which we did in collaboration with about 7 different sites, we looked at 200 patients who had negative conventional imaging, who were non-metastatic CRPC. The average PSA was 5. And in these patients, 98% of the patients had a positive PSMA PET, 98%. So there really is no non-metastatic CRPC. What's important is 39% of those patients had unifocal or oligometastatic disease. What that means is that maybe we can start using metastasis-directed therapy in early CRPC, and there's trials ongoing to evaluate metastasis-directed therapy in non-metastatic conventional imaging CRPC to see if we can push out metastasis-directed CRPC. We have a trial at UCSF called PILLAR where we're doing apalutamide versus apalutamide plus metastasis-directed therapy in this patient population. And will be interesting to see how RT or radiation therapy works in the CRPC setting. So we can think about non-metastatic CRPC converting into oligometastatic and low versus high volume. And then CRPC, we're going to talk in a second more about PSMA negative mixed disease and PSMA positive disease. So the last thing about PSMA PET I want to talk about is how PSMA PET will impact clinical trials. And I think this is really, I highlighted that with the STAMPEDE trial data and how, STAMPEDE in both charted, the inclusion criteria is going to change, but it's really becoming a problem for many clinical trials that are currently running and being developed. So as an example, I want to take this trial, NRG-GU10. This is one that I've been involved in thinking about how PSMA PET will impact this. So this takes unfavorable intermediate risk prostate cancer, randomizes them, or stratifies them based on Decipher score, and then based on the Decipher score, randomizes them to getting radiation therapy versus radiation therapy plus ADT, and then in the higher risk patients, ADT versus ADT plus darolutamide, so androgen receptor targeted therapy. This is in the intermediate risk initial staging patient. Now, if you think about this, the eligibility is going to be hugely impacted, right? So let's take this patient. This is a patient who would have met criteria for that trial. PSA of 24, Gleason 4+3, right? We now look at this patient. This patient has supraclavicular nodal disease, mediastinal disease. They have metastatic disease. This patient would never enroll in that clinical trial. So you're taking out the metastatic patients from that trial population based on PSMA PET, because you're not going to not treat this patient differently knowing where the disease is. You're not going to be willing to randomize them. So you're taking away the higher risk patients from that patient population, which is going to really impact the primary endpoints of that study. The effect here is what we would call a Will Rogers effect, right? So the trial design using conventional imaging might include these 90 patients, right? We'd exclude 10 patients based on metastatic disease with conventional imaging. But when you use PSMA PET, there's going to be more patients who have metastatic disease compared to conventional imaging. So you're taking out the poor prognostic patients from your trial design, changing your trial population dramatically, which is going to make your endpoint take longer for readout and going to change your statistical plan dramatically. The other thing that's interesting is that things like Decipher score are really correlated with metastatic disease and location of metastatic disease. So if you have a low risk Decipher score, you're not going to have a very high likelihood of having metastases. If you have high risk Decipher score, you're going to be much more likely to have nodal disease, which is not too surprising. Decipher score is supposed to predict the chance that you fail radiation therapy. Why do you fail radiation therapy? You fail it because the tumor's outside of the prostate. So no, it's not surprising that Decipher score correlates really closely with the presence of metastases. But now if we take out all of these patients with metastases out of your clinical trial, you're going to impact the outcomes of those studies. The other thing, and this might be a bigger issue, is if we start doing PSMA PETs after treatment, so patients have biochemical recurrence after you have your definitive therapy, you're now going to trigger your PSMA PET at time of biochemical recurrence, which is going to be before when you might actually see progression on conventional imaging. So we're going to start seeing progressive disease earlier than conventional imaging progression. And this is going to be a problem because PSMA PET progression is not a agreed upon FDA endpoint for metastasis-free survival. And we're going to impact our MFS endpoints because people are going to get metastasis-directed therapy based on PSMA PET results, which is again going to push out MFS and going to also hurt the enrollment or the readout of these trials moving forward. So you can sort of get just a flavor of how PSMA PET is going to dramatically impact patients on these studies. Okay, now I'm going to change direction completely and talk about theranostics. So theranostics is sort of a conflation of diagnostics and therapy, right? So we're doing therapies and diagnostics with the same molecule. So here you can see this is PSMA INT. It shares the urea motif of all the molecules I showed up in my third slide there. And in red is the DOTA chelator, right? So this is a chelator that grabs on to metals. Actually, it's interesting, this DOTA chelator is the same chelator that's used in dotarum, which is an MR contrast agent, interestingly enough. In this setting, though, we're putting radiometals in there. So we can put gallium-68 or copper-64. These are radiometals that we use for imaging. Or you can put in lutetium-177 or actinium-225 and use the same molecule, the exact same molecule for therapy. And obviously, it's this lutetium-177 that we're using for treatment in the setting of prostate cancer at the moment. Now, there are two trials that have been enrolled and read out with lutetium PSMA 617. One is the VISION trial and the other is therapy. And I think it's important to know both of these studies. On the left side there is the VISION trial. And for some reason, I decided to show the RPFS curves, but there's also overall survival benefit with 4 months of increase in overall survival with lutetium PSMA 617 compared to standard of care. Now, I should note the standard of care here is a little odd, right? So these patients are post-chemotherapy, post-abiraterone and enzalutamide, but the trial didn't allow any further chemotherapy or radium on the standard of care arm. They only allowed switch treatment with abiraterone or enzalutamide or other supportive measures. Now, that's sort of reasonable in the sense that you were supposed to be not chemotherapy eligible to be on this study. And also, it's not clear if chemotherapy, in addition to PSMA 617, would have been considered safe because there was no safety data of the combination. So not unreasonable, but a little bit unusual. So post-chemotherapy, 617 versus, in essence, no effective therapy, and that showed benefit. And this trial is what led to the FDA approval in March of lutetium PSMA 617. On the right is the therapy trial. This trial is different. This is a phase 2 study, okay, so not a phase 3 study. Overall survival wasn't the endpoint. The primary endpoints were PSA response and progression-free survival. And you can see here that the use of lutetium PSMA 617 slightly outperformed cabazitaxel. It was better, the odds ratio being 0.6, but it wasn't a dramatic improvement. And that, to me, means that lutetium PSMA is similar in efficacy to cabazitaxel. But there's an important point here. In this trial, lutetium PSMA was better tolerated than cabazitaxel. So from a tolerability and toxicity standpoint, lutetium PSMA is a very well-tolerated treatment. And so all things being equal, if you have someone who was treated with docetaxel, people are now, after chemotherapy, replacing second-line chemo with lutetium PSMA 617, primarily based on an improved tolerability and ease of administration. So patients tolerate it much better. Now, we do use PSMA PET for selection of patients, right? So we get a pre-treatment PSMA PET, and then we look at that and say, oh, you know, there's uptake there, and then we treat the patient. So this patient had an SUV max in the tumor of 31, the liver was 4, the parotid glands were 15, and you can see here, these are post-treatment images of that same patient looking at the lutetium. You can actually image the lutetium directly, and you can see actually the tumor melting away. You can actually dynamically see that occurring, right? That it's like getting a PSMA PET after every treatment, and the tumor is responding throughout this therapy. Now, one thing that's important to note is that there were different inclusion criteria in the therapy and VISION. Okay, In the VISION trial, and what's really standard of care in the United States is that uptake has to be greater than background liver. So this patient had an SUV max of 31, uptake was much higher than background liver. Not surprising, you see this very nice metabolic, it's not really metabolism because we're not doing FDG, but molecular imaging response of that patient over these 3 cycles. The therapy trial had an SUV max of greater than 20. You had to have a much higher uptake to meet inclusion criteria to therapy. And I think that's an important point to keep in mind, because in the therapy trial, I told you that there's only a small benefit of PSMA 617 compared to cabazitaxel. So likely, and I call it sort of the therapy vision gap, between the VISION trial inclusion criteria and therapy, there's probably patients who would actually do better clinically with chemotherapy than with PSMA radioligand therapy. Though, as I said, there's a lot of interest in PSMA radioligand therapy, and there's been this push to move towards PSMA radioligand therapy due to tolerability, which is obviously one reason why androgen receptor targeted therapy switch is more common than using chemotherapy second line in the metastatic CRPC setting in the United States. It's always interesting to me, and as an aside, I think something like only 18% of patients in the United States receive cabazitaxel prior to dying with metastatic castration-resistant cancer. So I think this is an issue where we undertreat patients with chemotherapy with this cancer, and I think this is going to be perpetuated by the approval of this drug moving forward. One other comment, so the drug here, I call it PSMA 617, but it's actually called lutetium-177 vipivotide. The brand name is Pluvicto. And I want to point out that in the package insert, it specifically states that patients for treatment should be selected using Locomets, which is, it's interesting to see, we make a generic PSMA 11 and then Novartis gets their own kit approved and they call it Locomets. That goes in their package insert. But really, it's PSMA 11 imaging was supposed to be used for selection of patients. But the question is, do you have to use PSMA 11 to select patients for radioligand therapy? And I and the NCCN argue, no, that's not true. So here's data showing that the liver, right? Well, right here, the liver, I thought I'd have a little pop-up thing. Right here, the liver uptake is the same with DCF-PYL and PSMA 11. So you should use either DCF-PYL or PSMA 11 to select patients for radioligand therapy. And we do not want the accessibility of PSMA 11 to prevent patients to get access to lutetium PSMA 617. Now, moving forward, there's a lot of stuff going on. So right now, lutetium PSMA 617 is over on the right side of this chart, and trials right now are moving this forward into the more upfront setting. So the PSMA 4 trial is taking patients after progression on abiraterone or enzalutamide, first-line androgen receptor targeted therapy, and then doing it randomized trial of PSMA 617 versus a switchover, right, going to Abi-Enza, and then looking at OS. This is sort of an odd trial, as we all know that second-line Abi-Enza isn't effective in these patients, right? Less than 10% have a response, but the FDA allowed this. So this is a phase 3 study that will move PSMA radioligand therapy pre-chemo. There are 2 very similar studies using that molecule I showed you, PSMA INT, in the exact same setting. It's interesting because PSMA INT is not patented. There's 2 companies taking the same compound forward. I don't think that's ever happened before in pharmaceutical development. So there's these 2 trials in the exact same patient population. There's also this trial, ENZA-P. This is a phase 2 trial out of Australia, which I find very interesting. So this is mCRPC. This could be first-line androgen receptor targeted therapy or second, as long as it wasn't enzalutamide, and looking at PSMA 617 in addition to enzalutamide versus enzalutamide alone. The idea here is that enzalutamide and AR targeted therapies can actually upregulate PSMA, particularly in patients who are failing treatment, interestingly. So PSMA 617 might work very well in addition to enzalutamide, and I'm really excited about the correlates on this, and Louise Emmett has done a wonderful job with this trial. It will be very exciting when this gets published, hopefully in about a year. Even earlier, this is in a charted population, so metastatic CRPC, and randomizing patients to ADT plus abiraterone versus ADT plus abiraterone or PSMA and PSMA 617. So this would be moving up front in the metastatic castration-sensitive prostate cancer. You can see slowly moving PSMA radioligand therapy earlier and earlier. You also have upfront PSMA. This is an academic trial out of Australia, ADT plus docetaxel plus PSMA 617 versus ADT plus docetaxel. I sort of like this trial better because there's only 2 doses of 617. This trial, PSMA addition, used 6 cycles. By the time you get out to cycle 6, there's probably no disease left, so you're just injuring the patient when you get that far out. But anyways, moving PSMA radioligand therapy earlier and earlier. And there's also a huge number of combination studies trying to improve the efficacy of lutetium PSMA 617. Obviously, people are going after DNA damage repair pathways, immunotherapies. I showed you the chemotherapy and the androgen receptor targeted therapy combination strategies that are being proposed. So really exciting time for this field as we really look to understand how to improve the efficacy of lutetium PSMA 617. Just as the last comment, these are example PSMA PETs across 4 different patients who are being evaluated for PSMA radioligand therapy. You can see how varied the disease is, both in extent, size, and uptake, right? Some patients have very high uptake, some have very low uptake, and we treat all of these patients identically with the same dose, same frequency, and same number of cycles. And I think moving forward, we need to reimagine how we do this, because some patients probably need more or to be treated differently instead of treating all these patients identically moving forward. So overall, in summary, there are actually now 5 approved NDAs for PSMA PET. 4 of them are PSMA 11s. We also have DCF-PYL, or piflufolastat, which is a fluorinated agent, is probably more widely available right now in the United States. PSMA PET impacts the management in up to 50% of men who are imaged for biochemical recurrence. And really the most common change in treatment is that planning for radiation therapy. And then the point I was making about trial design is really true. PSMA PET is wreaking havoc with trial design, particularly those where MFS is a primary endpoint, because PSMA PET is going to bring up the time point to progression than conventional imaging MFS. And then lastly, PSMA radioligand therapy is a new class of treatment for metastatic CRPC, and it's a really exciting time. I think next week is Novartis is on Monday just going to be starting shipping lutetium PSMA 617 after their manufacturing issues, and this new era is just beginning. So thank you very much for listening to me, and I look forward to having a discussion for a couple minutes here if you have any questions.
Thank you so much, Dr. Hope, for a great update on PSMA. Are there any questions?
Just as a reminder, you can type those up in the chat box or unmute yourself and ask Dr. Hope directly.
Dr. Hope, this is Karthik. Great presentation. Question for you. How do you discuss once a patient gets a PSMA PET and they ask you, how do you classify the disease, low or high burden in castration sensitive disease right now? You know, I know the trials are running, but currently.
Yeah. So first of all, there's no trial really running that's going to answer that question. There are trials running using PSMA PET. I won't address that question. So first thing I would say is I'm not a medical oncologist, so I never had this discussion with the patient. Secondly, I would assume a patient never would ask that question, right? It's you asking yourself that question of how am I going to treat this patient, right? So what are the choices here? Are you going to do ADT plus docetaxel? Are you going to do ADT plus abiraterone? And I think, you know, in the low volume patients, you're going to use ADT plus abiraterone, right? So that did not have the stratification of low versus high. And so the question is really, when do you convert from abiraterone, to me, in my mind, to abiraterone versus docetaxel? And in that setting, you probably actually want to be higher volume than in the charted trial, right? And there's no right answer here. And I would actually ask you as a medical oncologist, how do you decide when you choose, what combination you're choosing in the metastatic castration sensitive setting? Because I think really docetaxel is moving up into the more high volume setting in the CSPC setting, and ADT plus AR targeted therapy is sort of taking over the lower volume area. And I don't think we, even with bone scan and CT, have a definitive criteria of how you decide between those two treatments. But I would love to hear if anyone has answers to that question, because it's really an unknown answer moving forward.
Do we have any other questions for Dr. Hope?
Well, I hope you all order PSMA PETs and get patients on for lutetium PSMA 617 therapy, because it's a fun space right now and it's really exciting.
Great. Well, thank you so much, Dr. Hope, for being with us. We really appreciate it.
No problem. Thank you.
Thank you, Dr. Hope.